You about surgical site infections today. The objectives of the lecture is to provide an overview of the epidemiology of surgical site infections, to elaborate on the types of surgical site infections, which will be mentioned as SSI in the slide, to understand the role of antimicrobial prophylaxis in surgery, review the risk factors of surgical site infections, and to discuss the preventive strategies in surgical site infections. If you look at the importance of surgical site infections, both with regards to public health and with regard to clinical implications for the patient, it figures as the third most common cause of nosocomial infections, contributing to almost 14 to 16% of cases. SSI occur in 2 to 5% of patients undergoing inpatient surgery, and it is the most common nosocomial infection among surgical patients, about 38%, out of which 2/3 are incisional SSIs and 1/3 are organ or space SSI, the organs which may be accessed during surgery. With regard to the clinical implications, 7 to 10 additional postoperative days can be a result of such infections. It leads to increased mortality and morbidity. It costs a lot of money to treat such patients, and the use of antibiotics for such patients can also lead to an increase in antibiotic resistance. Up to 60% of SSIs have been estimated to be preventable if you follow evidence-based guidelines. You need to understand the differentiation between, or the differences between, colonization and contamination before we go on to surgical site infections. Colonization refers to the presence of bacteria in a wound with no signs or symptoms of infection, and the usual colony count is less than 10 power 5. Whereas contamination is generally a transient exposure to organisms, which can lead to varying concentrations of bacteria in the affected area, and the time of exposure suggested is probably less than 6 hours. A contamination can subsequently lead to surgical site infections, and this can be prevented by use of appropriate antimicrobial prophylaxis. We need to define surgical site infections at first. An infection is that which is associated with signs of inflammation, which is redness, swelling, pain, and warmth. Usual colony counts of bacteria are more than 10 power 5. This can be purulent or non-purulent, and it generally leads to an increased length of hospital stay for the patient and also has an economic effect for the patient. So a surgical wound is a surgical site infections, but sometimes surgical site infections may not be obvious as wounds in the exterior. To define SSI, this can be either incisional or organ space infections. Incisional infections can be superficial, which involves the skin and the subcutaneous tissue, and deep incisional infections involve a deeper soft tissue, whereas organ or space infection involves any part of the anatomy, either organs or spaces, which have been manipulated during the surgical procedures. This cross-sectional figure gives a very nice idea of the superficial surgical site infections, the deeper surgical site infections, and organ space infections. If you look at superficial surgical site infections, these involve mainly the skin and the subcutaneous tissue, and this generally occurs within 30 days of the surgical period, and it can be prevented by the use of antimicrobial prophylaxis. Deeper insulation infections are those involving the deeper fascia and the muscle, again occurring within 30 days after a surgical procedure, but can also occur up to 1 year after the procedure, especially if an implant has been placed in situ. The presence of any foreign body may delay the presentation or manifestation of a surgical site infection for up to 1 year after the procedure. If it is an organ or a deep space infection, which leads to an SSI, that involves the deeper areas of the surgical field, and this also can happen generally within 30 days, but up to 1 year after the procedure where there is any implant which has been put in situ. If you look at wound classification in general, it is classified into 4 types. Class 1 is clean surgeries, Class 2 is clean contaminated surgeries, Class 3 is contaminated surgeries, and Class 4 is infected surgeries. And in this, generally, prophylactic antibiotics are indicated for both clean contaminated and contaminated surgeries. If it's a dirty infection, then you need to give therapeutic antibiotics. The source of pathogens usually which contribute to the presence of infection can be from the patient's own body, which are endogenous. it can be the operating theatre environment, hospital personnel, whether it's a doctor, nurses, or other operation theatre staff, can all contribute to the organisms which may infect the patient, or it can also be due to the seeding of operative site from distant foci of infection in the patient's body, which could be an urinary infection or a bed sore or a distant infection in the nail, which can then affect especially implants in the patient. The endogenous flora are from the patient's skin, mucous membrane, and GI tract, and seeding from a distant focus can also occur. If it is exogenous, it is a soiled attire from a surgeon or a nurse's uniform. It could be breaks in aseptic technique or inadequate hand hygiene. All this can contribute to the bacteria which can contaminate the patient's wound. It can also be the physical environment in the operation room or inadequate disinfection of tools, equipment, or materials brought into the operation field. This slide shows the organisms which have been associated with surgical site infections, even though it is data from a decade ago. This generally holds true for most infections in surgical site in the West, predominantly Staph aureus, Coagulase negative staph, and Enterococci, which are all gram-positive organisms, and then subsequently E. coli, Pseudomonas, Enterobacter, and Klebsiella. In general, surgical site infections in Indian patients are more likely to be gram-negative, probably as a result of warmer temperatures or in general a greater colonization of the body with gram-negative bacteria, especially in the gut and other areas which normally have a higher prevalence of gram-negative bacteria. The pathogenesis of SSI is a result of interaction between the bacterial dose, the bacterial virulence, and impaired host resistance. So all these contribute to leading to a patient developing a surgical site infections. The risk factors for surgical site infections can be categorized as operations factors related or patient related. In general, the operation factors include the duration of the scrubbing time of the surgeon, whether the patient's body temperature is maintained appropriately, whether the skin antisepsis is adequate, preoperative shaving has been done or not, if so when and with what, the duration of the surgery, antimicrobial prophylaxis, the operation room ventilation, adequacy of sterilization and disinfection of instruments, presence of any foreign material or implants at the site of infection, presence of drains, the surgical technique involved, whether there has been adequate homeostasis, whether there has been failure to obliterate any dead space, tissue trauma, all of this can contribute to the occurrence of surgical site infections. The other factors may be patient related. This can be the age of the patient, whether the patient has underlying diabetes, the sugar control of the patient, whether the person's sugar has been adequately controlled in the previous several weeks before the surgery, whether the person is a smoker. It has been shown that nicotine delays primary wound healing. Use of steroids in the patient is controversial. Whether it impairs wound healing and increases the risk of infection is still controversial. Malnutrition has been found to have no epidemiological association, even though it is emphasized that adequate nutrition probably helps wounds heal better. Obesity, especially 20% over the ideal body weight, has also been shown to be associated with an increased risk of developing surgical site infections. One factor has been very clearly shown to be associated with an increased risk of surgical site infections, which is the prolonged pre-operative stay. So this is actually a surrogate of the severity of illness and the presence of other comorbid conditions. Preoperative nares colonization with Staph aureus also has a significant association with the development of surgical site infections. The use of blood transfusion during surgery or in the perioperative period is still controversial, but definitely the occurrence of coexisting infections at a remote site away from the surgical field is probably a definite risk factor for the development of infection, along with the immune status of the patient. The modifiable risk factors which can be worked upon to minimize the chances of surgical site infections are mainly the antimicrobial prophylaxis. This refers to the appropriateness of the choice, the timing, and the dose, and whether redosing has been done. If the skin site preparation is effective, and with regards to colorectal procedures, whether adequate bowel preparation has been done. The maintenance of temperature, especially again in bowel cases, is very important in contributing to contributing to surgical site infections. Hypothermia during surgery can lead to an increased risk of developing surgical site infections. The other factors which can be worked upon to minimize the risk would include minimizing the traffic in the operation room, inadequate wound dressing protocol, improper glucose control, colonization with pre-existing microorganisms, and an inadequate intraoperative oxygen levels. There was a study done, the National Nosocomial Infection Surveillance Project, which looked at the factors which probably contribute to the development of surgical site infections, and they found 3 independent variables were associated with SSI. These were the predominant 3 factors which were associated. If the wound was already infected or dirty, if the association of the American Society of Anesthesiologists classification was more than 2, which meant in a class from 1 to 5, where 1 was normal and 5 was a patient who was not expected to survive more than 24 hours, if the grading was more than 2, that definitely increased the risk of SSIs. And thirdly, the longer the operative procedure, time taken for the procedure, the greater the risk of SSIs. So what can the measures one can adopt to prevent perioperative infections and surgical site infections? The most important is surgical antimicrobial prophylaxis. This refers to a brief course of an antimicrobial agent initiated just before the operation begins, and it is actually an adjunctive preventive measure, and it should be appropriate. If appropriately administered, it results in almost a 5-fold decrease in the incidence of SSI. So the choice of the antibiotic has to be appropriate. You need to adjust the dosing based on the weight of the patient. You need to redose the prophylactic antibiotic if the procedure extends more than 3 to 4 hours, which goes beyond the half-life of the antibiotic. And sometimes a combination of parenteral agents and oral antimicrobials, especially in procedures involving the gut, play a significant role in minimizing SSIs. The principles of antibiotic prophylaxis are based on the fact that the person's skin is colonized by bacteria. A lot of them, usually the transient organisms, are removed by the surgical scrub or the disinfectant use on the patient's skin prior to surgery. But the organisms which are referred to as resident organisms, which usually stay in the crevices of the skin, the hair follicles, the sweat and saliva, sweat and the sebaceous glands, can all be still present and may not be removed by the routine disinfection used. So when a person's skin is incised, it is these bacteria which enter the skin field and subsequently cause surgical site infections. So the antibiotic you use should target the organisms which are on the skin, which are predominantly gram-positive. You need to have the timing right, which means that the antibiotic has to be given within 1 hour prior to incision so that the levels reached through an intravenous dose are maximal to inhibit the growth of these organisms. A repeat dose may be required if the surgery extends for more than 3 to 4 hours. And there is no role for antibiotics after skin closure, and definitely not extending it more than 24 hours after the surgery is done. So again, the choice should predominantly cover gram-positives, which are resident organisms in the skin. The timing should be within 1 hour prior to incision. It is usually parenterally given. Redosing may be required, and make sure that the dosing is appropriate, and the duration should be less than 24 hours. Now these are the recommendations from the Society of the Infectious Diseases Society of America, the American Society of Pharmacists, and the Surgical Society, which have come up with guidelines which came out in 2013 on the use of antibiotics. And you will find that most of the antibiotics are all first or second generation cephalosporins, which predominantly target gram-positive organisms of the skin. In some procedures, especially involving the gut, where contamination can be expected from gram-negative organisms in the gut, there are antibiotics, probably third generation cephalosporins or even metronidazole, which may cover for this. The list extends. Again, you will see that most of the organisms covered are targeting against gram-positives, so it is mainly first and second generation cephalosporins, and occasionally you may have third generation cephalosporins also. You need to also understand that redosing of the antibiotic may be required depending on the half-life, and this slide shows you what the dose would be and probably the recommended redosing interval which has to be followed to prevent the chances of infection, especially if the surgical time is prolonged. Another important aspect in the prevention of surgical site infections is hair removal. It is recommended that hair removal preferably be not done wherever possible, but if it is indicated, it should be removed by either a depilatory cream or by clipping and not by shaving with a razor. And if it is done, it should be done as close to the surgical procedure as possible. So doing the clipping just before the surgery will minimize the chances of infection when compared to removal of hair using a razor maybe the previous evening. It has been shown that the surgical site infection rates with a razor are almost 5.6%. With depilatory cream or no hair removal, it is as low as 0.6%. And the timing also matters. Shaving before 24 hours, 7.1%, as compared to shaving immediately before the surgery, which is 3.1% only. Several basic practices have been recommended for preventing surgical site infections. The importance of control of blood glucose immediately prior to the surgery, maintaining normothermia at least 35.5 degrees centigrade or more during the perioperative period, and optimizing tissue oxygen saturation, if necessary by supplemental oxygen administration, will also help in preventing the occurrence of surgical site infections. One has to use alcohol containing pre-operative skin preparatory agents. Use of impervious plastic wound protectors for gastrointestinal and biliary tract surgery is recommended. It is strongly advised that one follows the WHO checklist, which is available to ensure, and compliance is ensured for best practices to prevent SSIs. Antiseptic preoperative showers are also believed to be useful. They help to decrease the bioburden of the organisms in the skin and thereby minimize the occurrence of surgical site infections. Surgical attire is also important, but this is more to do with discipline rather than actual minimizing the risks of SSI. Proper scrub suits, caps, hoods, shoe covers, masks, gowns, gloves, they're all strongly recommended to ensure that you minimize the shedding of squames from the skin, which may contaminate the surgical field. Surgical technique is also very important. It is very imperative to remove devitalized tissue, maintain effective hemostasis, handling of the tissues should be gentle, dead space should be eradicated, presence of space available will lead to colonization, avoiding inadvertent entries into viscous, and appropriate use of drains and suture material are all strongly recommended. The physical environment of the operation theatre is also very important. Temperature should be maintained between 68 to 73 degrees Fahrenheit, depending on the normal ambient temperature. Relative humidity should be about 30 to 60%. Air movement should always be from clean to less clean areas, and the total air exchanges in a theatre should be more than 15 per hour, preferably involving at least 3 outdoor air exchanges per hour. The role of laminar airflow is still controversial. It has been shown that for orthopedic operations involving implants, there is a benefit. The surgical site infection rate has been decreased from 3.4 to 1.6% if ultra-clean air is used in operation rooms. It is also necessary that the surveillance of surgical site infections is carried out. You need to consider using automated data, provide ongoing feedback of the rates to the surgeons and other personnel involved in the surgeries and also to the leadership. You need to also measure and provide a feedback to the providers regarding the rates of compliance with certain process measures, all of which may contribute to minimizing the risk of surgical site infections. Education of surgeons, perioperative personnel about SSI prevention, and also educating patients and families about SSI prevention will play a big role in controlling this problem. There are some special approaches which can be followed in preventing surgical site infections. Screening for Staph aureus, especially in the nares, and decolonizing the patient with an anti-staphylococcal agent like topical mupirocin would help, especially in orthopedic and cardiothoracic surgeries. Performing antiseptic wound lavages in certain instances probably also help. A surgical site risk assessment has to be done so that you can target specifically to minimize surgical site infections. We need to observe and review OT personnel and environment of care in the theatre, and observation and reviewing practices in the post-anesthesia care unit, especially surgical ICU or surgical ward, all may contribute to minimizing surgical site infections. But what should not be done as a routine protocol targeting surgical site infections would be: do not use vancomycin as routine surgical prophylaxis, Do not routinely delay surgery to provide parenteral nutrition. Do not routinely use antiseptic impregnated sutures as a strategy to prevent surgical site infections, and do not routinely use antiseptic drapes as a strategy to prevent surgical site infections. So in summary, SSIs contribute to 2 to 5% of patients developing infections who undergo inpatient surgery, and this leads to increased morbidity, mortality, additional hospital days and expenses. Surgical site infections can be defined as superficial, deep incisional or organ space infections. Common pathogens include gram-positive organisms, staph, Staphylococcus aureus, Staph epidermidis and enterococci, though I would like to add in India, because of an increased presence of gram-negative organisms which may colonize the personnel, the risk of gram-negative infections is also high. The risk factors may be patient-related or operation theatre-related or perioperative factors. Surgical antimicrobial prophylaxis should be a single dose to be given within 1 hour prior to surgery, and redosing if the surgery lasts more than 3 to 4 hours. There is no role for prophylactic antibiotics beyond 24 hours after the surgery. Preoperative hair removal should be avoided, and if necessary restricted to clipping done as close to the surgery as possible. Maintaining euglycemia, normothermia and tissue oxygenation also helps prevent SSIs. It is very important that we follow the WHO-based checklist to prevent SSI. SSI surveillance and feedback to the surgical personnel may minimize SSIs, and avoid using vancomycin routinely or antiseptic impregnated sutures and drapes as a routine targeting preventing surgical site infections.